Today, we are jumping into something incredibly important for anyone in healthcare. We're doing a deep dive into the foundations of antibiotics. This is really the bedrock of nursing pharmacology, based on Chapter 9, and it's all about this constant war we're fighting against bacteria.
It really is a war. And our mission, when we use these drugs, is to understand the strategy. The goal of antibiotic therapy isn't to just wipe out every single microbe. It's a bit more nuanced. We want to decrease that invading bacterial population down to a level where the patient's own immune system can step in and clear the rest.
Okay, so let's start with how we categorize the enemy. I mean, we can't see them, so how do we classify them to pick the right weapon?
We use a few major tools. First, we look at how the drug acts. Is it bactericidal, meaning it kills the bacteria directly? Or is it bacteriostatic, which basically just stops them from growing and reproducing? It holds them in place until the immune system can catch up.
So with bacteriostatic drugs, the patient's own immune system is a huge factor in whether it works.
Right. Precisely. Yeah. If your patient is immunocompromised, those bacteriostatic drugs are going to be a lot less effective. You'd probably want a bactericidal agent in that case.
Okay.
Then the second thing is their need for oxygen. You have aerobic bacteria that need it and anaerobic that, well, they survive without it. They often hide out deep in abscesses.
And the last one, the big one you always hear about, is the Gram stain. Why is that simple little test so important clinically?
It tells us everything about the complexity of the bacterial cell wall. So gram-positive bacteria have a thick wall that soaks up the purple stain. Think strep pneumonia, respiratory infections, soft tissue stuff.
Mm.
Gram-negative bacteria have a thinner wall, but they also have this complex outer membrane that doesn't hold the stain. They're tougher to get through. You usually see these in GU or GI infections like E. coli.
That makes so much sense.
Yeah.
And that distinction leads us to the absolute gold standard first step,
Yeah.
the culture and sensitivity test. Why is that so non-negotiable?
Because without it, you're just guessing. You're shooting in the dark. The CNS tells you exactly what pathogen you're fighting and, maybe more importantly, which antibiotics actually work against it.
But what if you don't have time? The patient's septic, you have to act now.
That's when we reach for the broad-spectrum antibiotics. But that's where the danger comes in.
Right, because broad spectrum sounds great in theory, but it can mess with our own cells too, causing more side effects. It's that constant search for selective toxicity, isn't it?
Exactly. Hitting the invaders while leaving our own cells alone. And this is where it gets really interesting. Bacterial resistance. Bacteria are just incredibly good at evolving. They develop new tricks, They mutate.
What's a classic example of that?
Oh, the enzyme penicillinase. It's textbook. The bacteria literally evolved an enzyme that breaks apart the penicillin molecule, making it completely useless. It's why we have to keep developing new drugs. And it's why the FDA and the CDC are so adamant you have to take the full course of your medication.
It's not just about feeling better. If you stop early, you're leaving the toughest, most resistant bacteria alive to multiply.
You're essentially breeding the next generation of superbugs, and of course, never using them for viral things like the common cold. That's zero benefit, 100% harm in the long run.
And what happens when we go in with those broad-spectrum agents and just, nuke the whole system, good bacteria and all?
You get superinfections, you've wiped out the body's normal, helpful flora that keeps other things in check, like fungi and yeast. So when that flora is gone, those resistant organisms just take over. You see things like oral thrush, vaginal yeast infections, or really dangerous stuff like C. difficile diarrhea.
Wow. So to fight all this, sometimes we actually pair drugs up. That's the idea behind synergistic drugs.
Synergism is teamwork. The drugs work together to create an effect that's greater than what they could do on their own. The classic example is Augmentin. It's amoxicillin combined with clavulanic acid. The clavulanic acid doesn't kill bacteria. It just protects the amoxicillin from those bacterial enzymes, like penicillinase. It gives it a fighting chance.
Which means you can use a lower dose and get fewer side effects. That's smart.
Exactly.
Okay, before we dive into the specific drug classes, there's a huge safety point we need to talk about, especially for kids. It's about measuring liquid doses at home.
This is such a critical teaching moment. Parents hear teaspoon and they grab one from the kitchen drawer. But that is not a standard unit. They have to use a proper measuring teaspoon, which is 5 ml, the one from the pharmacy. Using a random spoon can easily lead to a significant overdose, and kids are so sensitive to these drugs.
Always verify the tool. Got it. Okay, let's get into the drug classes, grouped by how they actually attack the bacteria.
Let's start with category 1. The cell wall synthesis inhibitors. These are the drugs that stop bacteria from building their protective wall.
And the original, the patriarch of this family, is penicillin. What are the key things for nurse to watch for, besides the usual GI upset?
The biggest one, the huge red flag, is hypersensitivity. An allergic reaction can escalate to anaphylaxis incredibly fast, so you always check that allergy history. Also, most of them need to be taken on an empty stomach for absorption. Amoxicillin is often the exception there.
Next up are the cephalosporins. They're related to penicillin, so there's that cross-sensitivity risk, and they come in generations.
Yes, and the generations matter. The first generation is good for gram-positives. As you move up to the third, fourth, fifth generation, they get better and better at handling those tougher, more complex gram-negative bugs.
And beyond the GI issues, there's a really nasty side effect and a critical interaction to teach patients about.
The side effect is pseudomembranous colitis, which is a severe C. diff infection. It's more than just diarrhea, and the interaction is vital. Patients have to avoid all alcohol for at least 72 hours after they start taking it, or they can have a really severe flushing reaction.
Good to know. And rounding out this category are the carbapenems, the newer broad-spectrum guys for serious infections.
Right. And with them, the big concern is, again, severe GI toxicity, including C. diff. But there's a very specific drug interaction to watch for. They can cause serum valproic acid levels to drop. Since that's an anti-seizure med, a drop like that could put the patient at a huge risk for seizures.
Wow, that's a critical catch. Okay, let's move on to category 2. The protein synthesis inhibitors. These are the ones that mess with the bacteria's internal machinery.
First up, the Aminoglycosides. These are heavy hitters, used for serious gram-negative infections. They work by latching onto the ribosome and making it misread the genetic code.
But they come with a huge risk. What's the main safety alert for aminoglycosides?
The black box warning. There's a high risk of ototoxicity, that's ear damage, that can lead to irreversible deafness, and nephrotoxicity, which is direct damage to the kidneys. You have to be watching kidney function labs, BUN, creatinine like a hawk.
Okay, next are tetracyclines. They also stop protein synthesis, but they have a very famous absolute contraindication.
This is a classic one. Tetracyclines are a no-go in pregnancy and in kids under 8 years old. The drug binds to calcium and gets deposited in developing bones and teeth, causing permanent staining and pitting. Also, their absorption is tricky. Empty stomach, no dairy, no iron, no antacids nearby.
Got it. And the last ones in this group are the macrolides, like erythromycin, often used if someone's allergic to penicillin.
Yep. They also bind to the ribosome. Their side effects are generally milder, mostly GI cramping. They're a really useful alternative.
All right, let's move to category 3, DRNA and folic acid interruption. These go right for the bacteria's genetic core.
The Fluoroquinolones fall in here. They interfere with DNA enzymes, but this class has some really serious warnings from the FDA.
That's the tendon thing, right?
Exactly. A black box warning for tendinitis and tendon rupture, especially in older adults. They can also cause nerve damage and CNS effects. And like tetracyclines, they're generally avoided in kids because of potential cartilage damage. And another big teaching point is photosensitivity. Patients need to be really careful in the sun.
And what about the older class, the sulfonamides? Their mechanism is pretty cool.
It is. Sulfate drugs block a substance that bacteria need to make their own folic acid. Humans get folic acid from our diet, so it doesn't affect us. A great example of selective toxicity. But the side effect list is long. Risk of crystals in the urine, dizziness, and severe skin reactions like Stevens-Johnson syndrome.
And they're also a problem in pregnancy, right?
Yes, especially late pregnancy and while breastfeeding. They can increase the risk of something called kernicterus in the newborn, which is a type of brain damage from high bilirubin levels. It's very serious.
Okay, our final category, antimicrobacterials. These are for the really slow-growing bugs.
Yep. Think tuberculosis, TB, or leprosy. Treatment for these is a marathon, not a sprint. We're talking 6 months to 2 years, and always with multiple drugs to prevent resistance.
The two big ones are isoniazid and rifampin. And rifampin has that really famous side effect.
The one every patient needs to know about upfront. It causes a harmless but distinct orange discoloration of all body fluids. Urine, sweat, tears. We have to warn them it will permanently stain their clothes and contact lenses.
And the text also mentions the return of thalidomide for a condition related to leprosy.
Right, and it's such a good example of drug control. Because of its history with birth defects, it's only available under the strictest FDA rules, monthly pregnancy tests, 2 forms of birth control. It's a serious drug with serious restrictions.
So if we pull this all together for the nurse on the floor, What are the big lifespan considerations?
For children, you're always thinking about their sensitivity to GI and CNS effects and double-checking those doses. And you remember those hard stops? No fluoroquinolones, no tetracyclines.
And for adults?
With adults, adherence is key. But also, many antibiotics can make hormonal contraceptives less effective, so they need to use a backup barrier method. Critical teaching point. For older adults, they're just more vulnerable to all the adverse effects, especially to the kidneys and liver. You'll often need to adjust the dose based on their kidney function.
So what are the absolute core nursing considerations that apply to all of these classes?
It starts with a solid assessment. Check for allergies. Get baseline kidney and liver labs, your BUN and creatinine, and always check the CNS results before you give that first dose.
And during administration?
You give the full course on time. You watch the infection site. If it's not getting better, something's wrong. And you monitor for the specific toxicities of the drug you're giving. Aminoglycosides, you're watching hearing and kidneys. Fluoroquinolones, you're asking about tendon pain.
And the patient teaching to send them home with?
3 things, non-negotiable. 1, finish the entire prescription, even if you feel better. 2, drink plenty of fluids. 3, immediately report any scary signs. Hearing loss, severe rash, bloody diarrhea, or tendon pain. Those are emergencies.
Before we wrap, what about the newer drugs for the really resistant superbugs?
Right, so you have classes like the oxazolidinones. Linezolid is one. It's great for VRE and MRSA, but it's also a weak MAO inhibitor. That means a huge risk of serotonin syndrome if mixed with SSRIs, and patients have to avoid tyramine foods like aged cheeses and wines to prevent a hypertensive crisis. Powerful drugs, but they require a lot of management.
Wow, so this deep dive really shows the incredible strategy involved. The goal isn't eradication, but reduction. Resistance is always the biggest threat, and safety means watching for those really specific toxicities, oto, nephro, tendon rupture.
And that brings us to the final thought for you to chew on. With multi-drug resistant organisms on the rise and not many new antibiotics in development, how do we, as clinicians, ethically balance using our newest, most powerful antibiotic to save a patient today with the responsibility to preserve that drug's effectiveness for the patients of tomorrow who might be facing an even worse superbug?
That is a serious strategic question for the future of medicine. And that's all the time we have for this deep dive. We hope you feel armed with this critical knowledge.